Afternoon, everybody. My name is Hai Liang. I'm the moderator for this session today. So today we have Dr. Ong. He is a UMMC specialist. He's a specialist in internal medicine and infectious/communicable diseases. He is one of the nicest doctors that I have ever had the privilege to work with. Not work with, I don't work, but yeah. So he taught me during my third year, and now I would like to pass the time on to him. Oh, no, sorry, not pass the time on to him. Yeah, so we just have the discussion. So, Dr. Ong, how are you?
Yeah, I'm fine. How is everyone? I hope everyone is fine, stay safe, and maintain social distancing, wash your hands regularly, and if you're at home, make sure the frequent high touch areas are being wiped down.
Okay. So, doctor, have you met any COVID cases? I'm sure you have lah.
Oh yeah, we were a COVID hospital. We just disbanded the COVID team this week. Yeah.
So now still got COVID cases? No
Now
more.
there's no more cases in UMMC.
Oh.
Yeah, but the other normal cases are increasing lah.
Yeah lah. So dengue and whatnot lah, is it?
Yeah.
All right.
Usual cases. Yep.
Yeah. So we'll go on to the next topic. So Nuri, next slide, please.
Yep.
So welcome guys to Case by Case Basics session 2 with Dr. Ong. So our first case for today. Next slide. Okay, so Madam It is a 38-year-old lady presented to the clinic with 3 days of history of intermittent fever associated with lethargy and malaise. So Dr. Ong, just like to pick your brain a little bit. When you see a case like this, what do you think of first?
Oh, what do you think of first?
Well, since this case is dengue, right? This session would be dengue, so I would think of dengue. But for me, this would be in non-specific lah. For me, I would think, oh, fever, lethargy, malaise. I would get that all the time. I don't know if I would admit this patient or not.
Yep.
So that's what a layman would think lah. I'm a layman. So what do you think?
So, well, she's a young lady, right? Young lady, with a short history of fever and lethargy and malaise. This is something like acute undifferentiated febrile illness. So, in this part of the world, dengue has to be high up in our differentials. And of course, we should not miss out other potential cause as well. Okay, so let's go on to the history.
Okay, Nuri, next slide. All right. So for the presenting complaint, the patient presented to the clinic with 3-day history of intermittent fever, no observable variation in the fever, and associated with chills and rigor. Unfortunately, she did not take her temperature at home, but she did go to KK, and on day 1 of the fever, the temperature taken was 39.8 degrees Celsius, which is quite high. The KK diagnosed her with tonsillitis and gave her antibiotics. Okay, next slide. So associated symptoms are as follows. So first would be again lethargy and malaise, progressively worsening until her chores and daily activities are affected by the tiredness. She also had a headache with a pain score of 4. It's banding in nature, so from the forehead all the way to the back. She also complained of some myalgia and arthralgia, loss of appetite and reduced fluid intake. She did say she reduced the fluid intake to about 2 cups of water or 1 cup per day. So as a result, her urine would be concentrated, yellow in color, and frothy. She also did complain of an epigastric pain, which is intermittent in nature, 3-day history of pain, with a pain score of about 4. She also had some diarrhea 3 times a day, moderate and watery. So, oh, someone asking a question. So yes, Osnil, what's your question? Hello, Osnil.
Oops,
Sorry.
sorry.
It was
Oh,
a
okay.
there was a lag.
Oh, okay, okay.
Yeah, sorry.
Okay, no problem. So anyway, so doctor, just like to ask you, so when you see all these associated symptoms, again, what do you think of? Because what I would think of is, again, this could be anything. This could be an acute GE. Uh, it could be something else, some viral flu, viral pneumonia. Anything could be possible. So, doctor, what would you think of?
Yeah, of course. Like this, if it's in this part of the world, of course, in this season, like after rainy season and so on, we have to think dengue high up in the list of different shows. So with all these symptoms that we are getting from the history, if this patient is having dengue, then he's having quite a bad dengue, as in he has some of the warning signs that we taught you, right? I mean, they have this lady has been having diarrhea for 3 times. Looks like dehydrated because the urine is reduced and very concentrated, and also has this lethargy. Well, lethargy is a bad warning sign, um, and also the epigastric pain. Well, I'll talk to you. We will talk about how these symptoms come about, lah. Okay, after this. Yeah, can you carry on?
Okay, so next slide. So for the remaining part of the history, just like to point out, she has no medical or surgical history. Drug and allergic history is not significant. For family history, her father had coronary artery disease, her mother had diabetes and hypertension, but there was no family history of prior dengue. For social history, she lives with family in Puchong, works as a clerk, doesn't smoke or drink or use illicit substances. However, she did note that fogging was done last week in her neighborhood. So I'm sure that's a relevant history. So next. Okay, so physical examination, there are more positives. So for general inspection, she is pale, lethargic in appearance, pink on air, however slightly tachypnic with a capillary refill time of 3 seconds. Conjunctival pallor was noted. Her mucosal surfaces were dry. Her extremities were cold and clammy with no cyanosis, no jaundice, and a full Glasgow coma score. So based on this general inspection, does this further your differential diagnosis of dengue, doctor? Would it put it higher up on the list or alert you to anything else?
Yeah, because you look at the clinical finding of like this patient is having tachypnic. Well, anything that is above 20 breaths per minute is considered tachypnic. So why is the patient having tachypnea? So things must come to your mind like what is the cause of his tachypnea? But putting together the symptoms, the fever, and all the warning signs that we are getting, in the case of dengue, you want to think about whether this patient is having some metabolic acidosis that the body is trying to compensate by hyperventilating. And you're looking at the CRT 3 seconds. Even if the CRT of 2 seconds only, it should be less than 2 seconds. Even a CRT of 2 seconds is considered prolonged, right? It's considered prolonged. That means the perfusion is impaired already. So this you must be able to pick up. And the conjunctival pallor, so you must think about like if the patient is having any bleeding right now, why is this lady having a pale? Why is this lady pale? Is she bleeding somewhere, or she has anemia from before? And when you look at the vitals, so what do you think of the vitals? Anyone that want to interpret this part of the vital signs there? What are we dealing with if this case is a case of dengue fever? In the case of non-dengue fever as well, if you look at the vital signs like this, BP of 90/61, temperature of 38, pulse rate of 124, slightly tachypnic breath, 22 breaths per minute, plus the peripheral perfusion that is impaired. So putting together, this patient is unstable right now. Definitely is unstable. You have to do something immediately. So to summarize everything, whether it's if it's dengue, what kind of dengue at what stage of the disease that we are dealing with now? Anyone want to give a shout out?
So Tan Hak Ki said they are signs of dehydration and possibly impending shock.
Impending shock. So I would say that this patient is already in decompensated shock lah. If we use the dengue terminologies, you have dengue with warning sign, dengue with incompensated shock and in decompensated shock. So looking at the blood pressure that is low, heart rate that is very high, right, and got some other signs that suggest poor peripheral perfusion, this patient right now is actually already in decompensated shock. So it's at the very late stage of this severe dengue right now. This patient will die if you don't do anything fast. Okay, let's carry on.
Okay, so go back. So doctor, just like to point out the BP, yeah. So in the dengue CPG guidelines, it stated that compensated and decompensated shock, there is a column there which is pulse pressure. So I found conflicting information online. So I'm not sure if this is considered a normal pulse pressure or not.
So to see the pulse pressure right now is about 37. So when we take care of patient, we look at the trend. So we don't just look at one reading and say that unless it's very obvious that it's very narrow, right? So we don't know what is the size of this patient, what is the normal BP, right? If we are able to get that piece of information, what is the normal BP of this patient when she's stable, very well that time, the baseline blood pressure, then we will be able to tell more clearly. Otherwise, we need a couple of readings, perhaps like, maybe 15 minutes apart or 5 minutes apart, and to see if there is any further drop, further narrowing of the pulse pressure or not. So that will be helpful in monitoring the patient.
All right. So the last question for this case, I'd just like to know what does the downers over throat space would mean in this case?
So
would this be relevant for a dengue case?
Oh yes, we always have to think broadly. Of course, we need to think dengue as high up in the list of differential, but we also must not forget other potential cause, of the patients. I mean, we also must think a bit broadly, like not just confined to just dengue alone. All right. So in the scenario of a dengue patient, if there is downers at the throat space, and when the percussion is performed when the patient is lying down, so, it could mean something else, such as, you want to try?
Oh, asking me? Oh, I'm not sure. Maybe a viral infection causing some congestion in the spleen.
How about the effusion, pleural effusion, or some ascites that the patient is having? Right, because the pathophysiology of dengue, they will have this plasma leakage, capillary leakage, plasma leakage into the third space, right? So the pleural is a space that you can have pleural effusion there, and also peritoneum is another third space that fluid can accumulate there from the plasma leakage. Okay, so besides plasma leakage, looking at the vital signs and the clinical picture of this patient, you also must think about whether those fluids are just simple plasma or, is this patient bleeding? That's why the downers. Yeah, so dengue is also a bleeding, is a bleeding disease. Looking at the parameters like that, with all the tachypnea and all the decompensation, bleeding also must be in your mind. Okay?
I see. Right. Okay. So, okay.
So is it this case?
What's this?
That's all, is it, for this case?
Yeah. So I didn't include the investigation because it's as you expect lah. Dengue serology is positive, and then some hematocrit risk, stuff like that lah. And the management is typical.
Okay.
So we just move on to the next quiz. So the next case, I want to go a little bit. Before that, Lau Kai Xiang asked, so as we know, the symptoms of dengue and chikungunya are very similar. How do we differentiate these two differential diagnoses based on the history and PE?
All right. So chikungunya, the characteristic of chikungunya is the bone pain and the muscle ache that is disproportionate to what you might be expecting. So, and they might have some raised CK from there as well. It will be difficult to differentiate, but clinically, the symptom might be able to tell us because the pain is more severe compared to dengue, and the pain in chikungunya actually can last longer compared to the myalgia arthralgia of dengue fever. Even when the patient has recovered, there were reports that says, the patients who has chikungunya still has this pain, joint and muscles, even after when they recovered. Yeah.
Okay, so thank you, doctor. So we just like to move on to the next next case real quick. So just very quickly, so Madam Kaur, a 63-year-old female, presented with a 3-day history of intermittent pain associated with generalized lethargy. Underlying 15 years of diabetes mellitus, 10 years of bilateral knee osteoarthritis. She is referred to your clinic after platelet count seen to be reduced, which is 120 times 10 to the power of 9 per milliliter. So again, does this look like a dengue case to you, doctor, at first glance?
Well, it can still be dengue. Anyone else want to try? Like, what do you think that this could be? Anyone? Anyone from the 128 people here? Anyone want to try? What do you think, Hai Liang, of this clinical picture? Fever, lethargy.
Yeah, so before I proceed to assume that this should be dengue, I will probably look at the underlying. So any medication that she's taking, so maybe bilateral knee osteoarthritis means that she's taking some steroids, Cushing, maybe could lead to the thrombocytopenia, or it could be just another viral flu or viral pneumonia, because anything viral, I would say, could cause the thrombocytopenia in patients.
How about NSAID? NSAID is something that you should not forget as well, because somebody who is having OA, so many of them will be put on some kind of NSAID. So NSAID will lead to sometimes bleeding, sometimes peptic ulcer disease, and because of that, some have this blood loss, chronic blood loss or something. Then that may cause the lethargy that she's having. But then again, this lady is having fever, right? Fever, low platelet. So let's see what else do we have from the history.
So next. Okay, so for the presenting complaint, kind of typical. So 3 days of history of fever with chills and rigor, not resolved after ingesting paracetamol. Moving on, next slide. She also has loss of appetite, lethargy, but she does have some cough and some chest pain with runny nose. So after listening to this, doctor, what would be in your mind?
In my mind. Right. So this patient is having like a fever, cough, and some chest pain. So is the chest pain like pleuritic in nature? I know it's exacerbated by coughing, but exacerbation by coughing doesn't mean that it's pleuritic, right? So what do you understand about by pleuritic chest pain?
So a pleuritic chest pain, as I would understand it, is exacerbated by taking deep breaths. Am I right?
Yeah, you remember, huh?
Yeah, you talk well, doctor.
Yeah, so that's the definition. So well, it can still be pleuritic chest pain. There's some localized chest pain as well. So perhaps there's some localized etiology over there. It could be a lobar pneumonia that we are dealing with here. But then again, she also has some blocked nose. So, well, the differential can be quite wide. It can be a lower respiratory tract infection, or it can be things like, influenza, or even some other viral pneumonia is possible as well. Because, as you know, viral infection is pretty non-specific, and lethargy, all that loss of appetite is pretty common in any viral infection. And viruses such as pneumonia, MERS, some other RSV, respiratory viruses can cause this as right. Okay, let's go on.
Yeah. So next. So okay, before we go on, the patient was tested to have negative dengue serology lah. So basically, this is not dengue.
Right. So what are we looking for in the dengue serology? I mean, looking at the history of day 4, right? Day 3 or day 4?
Yeah, day 4. So day 4, you will look for IgM. The NS1 also might be positive, but IgG would be negative in most cases, I think.
Yeah, unless they got the dengue fever before this years ago, they still might be IgG. So the thing that we are looking for in day 3 like that, so usually it's still NS1. IgM may not come up in until day 5 or day 8 of illness. So IgM may not be present. And even then, during this time, if the history and the epidemiological link is very suggestive of dengue, we still cannot forget dengue, despite the test is negative for NS1 and IgM. Okay, because day 4 is the day when the antibody starts to build up, but it's not at the level that is detectable yet. And this is the time when the antigen level is, coming down, when the antibody is being built up. So during this time, you can expect, even in dengue fever, you can probably expect a negative test result at this window during these few days before the IgM is detectable, right? So just don't dismiss dengue if clinically is suggestive. What we can do is we can hydrate the patient if necessary, because she has this loss of appetite and lethargic. We have to assess the patient clinically thoroughly to see what is the perfusion like, what is the pulse volume like, what is the hydration status of the patient, how much the patient can take, and how much urine comes out from there, and to decide on how much fluid that we want to give this patient. At the same time, we can work her up for the other causes. Even then, we must not forget to do like a serial full blood count for her, because if it's really dengue during this time, when going to the effervescent phase, you will expect to see a drop in white cell and also a drop in platelet count. So if that happens, despite having a negative NS1 IgG at this window, then you still have to treat this patient like a dengue fever patient. Okay. Yeah, of course, you can also, depending on the symptom, you can also start to screen this patient for maybe things like influenza or RSV.
I see.
And looking at the exposure history in this time of the year when the COVID-19 is still happening, so you must not forget to ask detailed, thorough history about the exposure, travel, and other history. So that we get to rule out, or whether they are suggestive, whether we need to work them up for COVID-19 or not. Okay.
I see. All right. Thank you, doctor. So that's it for this case. We will move on. So this case is a little bit more chronic. So Mr. Akmal, 30-year-old gentleman, presented to the clinic with a 4-week history of fever and cough. So that's it. So moving on. So the presenting complaint would be that the patient had 4-week history of intermittent fever, no observed pattern of variation. The temperature ranges from 38 to 39 degrees Celsius, but dips to 37 degrees Celsius when the patient takes any paracetamol. He takes paracetamol to only control the fever when needed, so PRN. The fever is associated with chills and rigor, lethargy, vomiting, night sweats, and intermittent diarrhea. Oh, sorry, I missed out cough, and cough. So for negatives, the patient is not short on breath, no URTI symptoms, no constipation, no loss of weight, no loss of appetite, no TB contact, no dysuria. So doctor, right now, what is the clinical picture in your mind? What do you think of?
Okay. Any volunteer from the students? I mean, I can tell you my my thoughts, but if anyone want to try, that would be good too.
Okay, so Lau Kai Xiang said seroconversion of retroviral disease, pneumocystic pneumonia, penicillosis, histoplasmosis, or COVID-19. Teo Yik Peng said pulmonary TB. Raymond said TB.
COVID-19 don't give you fever for 4 weeks, right? Seroconversion of RVD, it's possible. PJP, yes, if the patient is having HIV or immunosuppressed due to some other reason. Penicillosis, histoplasmosis, if the patient is immunosuppressed, you have to think of that as well. Pulmonary TB, yes, we have to think about pulmonary TB high up in the list in this part of the world, yeah. And colitis, yes, possible. But how about we put things into a more systematic way? This might be helpful for you in the future when you deal with clinical cases, even at work later on. So you should divide the causes or potential causes into a couple of big groups, such as infection, all right, and then malignancy, connective tissue, drugs, all right, a few big groups so that you don't miss out on anything. Then from each of the bigger groups, such as infection, then you can talk about tuberculosis, PJP, maybe abscess somewhere, right? Or osteomyelitis somewhere, or melioidosis, right? So in terms of the history, the occupational history, the travel history, you know,
Doctor, you unmute yourself already.
Oh, I muted myself. Okay.
Yeah, I didn't hear what you.
Yeah, so I was telling you have to get more history in terms of the occupational history, the travel history, and the exposure history. So that will be helpful in narrowing down our differentials. For example, if you're somebody who is a farmer who has exposure to dust and so on, so they might be at risk of getting melioidosis, right? And somebody who has exposure to red urine, for example, they swim in some leptospira infested fresh water in a lake or in a river or in some still water pond or something. So they are at risk of leptospirosis, right? If they have history of this travel and stayed in some hotel where the air system is contaminated by Legionella or some atypical bacteria or mycobacterium, so they are at risk. Or they are at risk of getting all these atypical pneumonia organisms. Yeah, and if they are exposed to somebody who has tuberculosis, then they are. I mean, that could be a differential diagnosis. So the history taking part is very important, and the occupational history is important as well. For example, if this patient is a farmer or a sewage worker, yeah. Or if they travel to some endemic area for some, or eat some exotic food, uncooked, drink some unfiltered, uncooked water. So they are at risk of getting all the funny parasites or other infections. So this part of history is Very, very important in this kind of case. So do not forget to take this part of the history, right? But if in this part of the world, we want to think about tuberculosis in this patient, looking at the history of presenting complaint.
I see. So basically what you're saying, doctor, is that the presenting complaint is not enough to make a diagnosis. The diagnosis is still quite broad, is it?
Yeah, but basically, in short, it's a case of prolonged fever and cough, right?
Yeah.
Yeah, so you have to go along the line of like TB pneumonia, PCP, or something to do with the lung. Why is this patient coughing, right? That should be high up in your differential.
I see. Okay, so we have a question from Tan Hak Ki. So he's asking, how do we define no TB contact?
Well, you asked about if they have any household members of the household who has TB, any contact with foreign workers who is TB, because we come across people who handles foreign workers, right? Those NGO advocates and those managers of foreign workers in an orchard, in a farm, and so on. So these are the history that you should be getting as well. You might not getting something positive, but if you don't ask, you will not know. If you ask, and if there is such history, then it supports your differential and supports your, contributes to the your ability to make a narrowing down the diagnosis. Yep.
I see. So, doctor, just now you mentioned PCP, right? So I'm just wondering, do you often think of PCP when you hear something like a long fever and long cough?
Well, so we have to put not just looking at the symptom alone. We have to put all the clinical pictures together, right? So especially if this patient is somebody who's immune suppressed, having HIV, then PCP, of course, is one of our differential. And clinically, if the patient is hypoxic, then you want to think about PCP. And if the chest X-ray, there are some pathognomonic, features that can tell us that this looks more like PCP rather than TB. So if you get all that together, then it could be high up in the list before we do some confirmatory tests.
I see. So I've read in the textbook, what they say about PCP is that PCP will often present in patients who are immunosuppressed or their CD4 count in HIV patients. So their CD4 count will be less than 200. So it often presents in these groups of patients. So in normal patients, will that happen, or it's totally impossible?
It's less likely. But then again, it's not only HIV that causes immune suppression, right? So there are this group of people, patients who are having chronic tissue disease, that they are on steroids for long term. For example, SLE patients, some Still's disease, arthritis, RA patients, those transplant patients, right? They are immunosuppressed. They are on immunosuppressant, and at the same time, those dialysis patients as well. In a way, they are somewhat immunosuppressed, and patients who have uncontrolled diabetes and all that. Yeah, they have this suppressed immune system, so the risk is there. The PCP is just in the environment. You don't get it, I don't get it, because our immune system is good, our CD4 is good, right? So, but if in somebody who is immune suppressed because of drugs or some medical condition, then they have this risk of getting PCP.
I see. Okay, so I think that's all for the presenting complaint. So maybe you can move on. So the associated symptoms for these patients would be a 4-week history of dry cough, no sputum, no hemoptysis, some lethargy. The patient describes it as being consistently tired, affecting his productivity at work. He also complained of some vomiting, which is intermittent in nature, 2 to 3 times a week. The vomiters contains food or it's watery, depending on what food or water he consumed prior to vomiting. He also complained of night sweats and intermittent diarrhea, no blood in stool. The stools are watery and about 3 times a week. So do you have anything to add here, doctor?
Okay, in the history also, I think you need to add in about ask the patient if there is any nodular swelling that they realize around the neck or the axilla. You know, TB also, any infection in the lung. I mean, when you do the examination, it's not complete without doing a neck examination to look for any palpable lymph nodes, right? So especially in the case that you suspect TB, you must check the cervical group of lymph node thoroughly. Look at the axilla as well, because you want to look for any lymph node that is palpable. And if somebody is immunosuppressed, this patient has some bowel symptom as well, vomiting and so on. So you want to ask, diarrhea. So whether this patient is having any colitis as well, right? I mean, like one of you, Lee Sin, said colitis. Yeah, so colitis can be infective or non-infective as well, right? So it can be infective or it can be inflammatory, such as Crohn's disease, or the other ulcerative colitis, the inflammatory colitis, right? So so we have to get more history to get to narrow down the differential, lah, right? Yeah, so the history is very important as well. So you need to explore more about the risk factors, such as whether got any multiple sexual partner, unprotected SI, whether they share needles, whether they use injectable drugs, things like that. Yeah. So from there, then we can explore further and get a further understanding of what is going on with him and where should our direction of investigation be.
I see. Okay, so next. Okay, so we just skip all that because this is not the case. This is not this is a hypothetical case. So let's say during the physical examination he inquires about STD tests. After further probing, he reveals that he is actually gay and had sex with multiple male partners in the past 2 years, sometimes unprotected. So when you hear that, you proceeded to do the lymph node examination and found a bilateral cervical lymphadenopathy in the anterior jugular chain and bilateral supraclavicular fullness. So like you just mentioned, right? So have to do a neck examination to check for lymph node swelling. Could be a sign of TB. Yeah. So what I've read is that sometimes HIV during the seroconversion phase, they could have something called the persistent glandular lymphadenopathy. So is that something that we need to keep an eye out for or not?
Well, I think first and foremost, we have to rule out that something that is more urgent and more treatable, that is more urgent. Things like TB, those infection, or even malignancy. As we all know, HIV patients or those who are immune suppressed, they are at a higher risk of getting malignancy, like lymphoma, right? Hodgkin or non-Hodgkin, they are at high risk because their immune system is gone. So immune system or the white cell, in a way, immunologically, it has a role to contain some abnormal cells before they become cancerous, right? So now that your white cell, your immune system is gone, so they're at high risk of getting malignancy as well. So infection, malignancy, we have to rule that out first before we pay attention to something that we cannot do anything, right? So we have to rule this out first by doing further investigation, such as a biopsy or excisional biopsy for culture, for TB studies, direct smear, TB culture, and also for histopathological examination. So there are certain characteristics that suggestive of TB, like your caseous necrosis when you look at the lymph node under the microscope, or whether there are other features that suggest other things, or whether they see all these malignancy cell, blood cells inside the lymph node or what. Yeah, so that will be the next step from here. Yep.
Okay, so basically to rule out other more important things first.
Yeah, of course.
Okay, so this is the third case. Now let's just move on to the final case. So this patient is a non-HIV patient, so it makes things a bit more simple, I guess. So this patient is Mr. Shark, 27-year-old male, presented to the STD/HIV clinic for follow-up. So he had previously missed his follow-up appointments, but is brought to the clinic this time by his mother. So he has an underlying retroviral disease diagnosed about 2 years ago, and MDD, major depressive disorder, depression, diagnosed by psychiatry department 6 months ago. So next. So his presenting complaint is that this time that he has 1 month history of fever, intermittent in nature and worsening at night. So it's associated with chills and rigor, no night sweats, but associated with diarrhea, vomiting, lethargy, dry cough, loss of weight, and loss of appetite. So doctor, what is going through your mind right now? Is it the same as the previous patient?
So right now, the patient is already on treatment, right, for TB, or have you come to that?
No, not yet. He's actually he is supposed to be on treatment, but he's not compliant to the medication.
Yeah.
So that's in the next. Yeah.
So right now, you know that he's immunosuppressed, he's not compliant to the medication, and many infection can invade this patient's body lah. And of course, TB is higher on the list, PCP is higher on the list as well, and plus all your diarrhea and all that, we have to think further, as in whether it's a fungal infection, you know, like a fungal that causes the pneumonia, and some other parasites that causes the diarrhea. Yeah. So we have to think more on that. Or is it like a virus that normally don't that normally don't cause diarrhea? Things like CMV, they can cause CMV colitis, and sometimes can cause pneumonia as well. Some of the viruses. Yeah. So we have to think along that line. Yep.
So, doctor, just like to ask, because if you look at the textbook or you look at Google, when you type in what's that called, opportunistic infections, there will be a whole long list of infections. So, just like to know, as you mentioned, TB, PCP would be more prevalent in this part of the world. What other opportunistic infections or AIDS-defining what's that called? AIDS-defining diseases, I think, would you be more aware of?
Well, things like Cryptococcus, meningitis, okay, and PCP is one, TB. Yeah, so basically what you can do is we can go according to the symptom. So from head to toe, you do not miss any part of the body. So besides knowing the infection, we also need to localize the infection, right? So we have to do some history, physical examination to localize the potential site of infection first. So then from there on, we will probably know, what potential infection is the patient having. Toxoplasmosis, so we always go according to, what we like to do is we don't miss out the systems. We go from head to toe. So from the CNS wise, you need to think about like Cryptococcus meningitis, strobotoxoplasmosis, right? Of course, other differentials as well, other parasites, those cysticercosis, you might not want to rule out, not want to dismiss that. And then you go to the lymph nodes and so on. You want to look for evidence of possible lymphoma, right? And then you go down to the lungs to see any infection there. So infection in the lung can be your virus, can be your bacterial, including TB, or other atypical mycobacterium like your Mycobacterium avium, Mycobacterium abscessus, and so on and so forth. There's a whole family of them. And then you want to go to the heart to see if there's any infective endocarditis. And then in the lung as well, you don't forget the fungus like histoplasmosis, aspergillosis, right? Those are, because they don't have immune system, all these fungus can easily colonize and cause disease in these patients. Yeah. And then you go to the bowel, the tummy area, whether they have any colitis, whether it's from virus or bacteria, right? And then anogenital area, right? And then you look at the generally you look at the skin as well to see if there is any rash of concern, whether it looks like a syphilis rash or whether it looks like Kaposi sarcoma. Okay, and then of course you look at, don't forget the joints, feel the joints of the body to look for any arthritis, so on. Don't forget the back as well. Turn the patient around, look for any carbuncle, abscesses, and so on. Don't forget the eye and the ear as well, because somebody might have endophthalmitis due to CMV, retinitis, due to some of these opportunistic infection. And also don't forget the ears. Yeah, these are some of the places that we sometimes overlook. Yeah, so don't forget the eyes, the ears as well. Look inside the ear by otoscope if you are able to see something there, otitis media or externa. Then yeah.
I see. So Li Yixing asks, can it be disseminated TB that caused the diarrhea and all the other symptoms?
Yeah, possible.
Yeah, and is disseminated TB more common in immunosuppressed patients?
Yeah, of course. The more immunosuppressed you are, the more culture plate-like your body is. So your body is like a culture plate for all the bacteria, all that to grow if you don't have all the white cell and defense system in the body. Yeah.
I see. Okay, so we can move on. So next, so associated symptoms, again, cough, 1 month history of chronic persistent dry cough. In some episodes, you could not breathe, so that's one. Diarrhea 4 times a day, no changes in stool color, watery solid stool, and reduced in amount. Vomiting is food, non-bilious and no blood. Lethargy, generalized weakness, 1 month history. And loss of weight, which is 11 kg in 1 month, loss of appetite too. But relevant negatives would be no night sweat, no shortness of breath, no hemoptysis, no chest pain, no abdominal pain, no rash, no dysuria, no headache. So, doctor, I'd just like to ask, what would be the relevant negatives you would want to ask in a patient such as this?
So like I told you just now, you have to go from the head to toe. So you need to rule out meningitis. So you ask about what? Photophobia, neck stiffness, neck pain, headache, right? Worsening headache, those kind of symptoms, projectile vomiting. And then you go down any nodular swelling around the neck that you can feel. If they have any respiratory symptom like cough, I mean, he has hemoptysis, and how is it like? So for every complaint, you have to explore that complaint. For example, if the patient has cough, you have to ask, when is the onset? What is the progression like? Whether it's increasing in frequency, increasing in intensity, and other associated symptoms like hemoptysis or yellowish sputum or whatever. Whether there is any diurnal variation, whether it's worse at night or worse in the daytime, any aggravating factor, relieving factor. So you have to explore each and every complaint if there is any. 13 or 15 questions there is to ask for each complaint, so that you don't miss out and you know where to go from there because if the cough that is just lasted for 3 days may not be significant compared to a cough that lasts for 2 weeks, and in these 2 weeks it's progressive and as well with some shortness of breath and so on. Ask about the obstructive symptoms. If there's a cancer there, a mass there, then this patient might be having dysphagia, odinophagia, things like that, right? So you have to explore the history, like a step-by-step kind of thing from top to bottom. So then you ask about any cardiac symptom, like a palpitation, chest pain, decreased effort tolerance, and so on, shortness of breath, yeah? And then regarding the abdomen, bowel symptoms, diarrhea, constipation, altered bowel habit, tenesmus, blood or mucus in the stool and all that, right? So that has to be addressed as well. Other symptom, other part of the body. So you go by systematic so that we don't miss out anything.
So doctor, just like, so doctor, just like to ask, So, for example, if a case like this comes out in the final year exam, for example, so there may not be that much time to ask all the questions. So, what do you think we should emphasize on?
You should practice.
Right.
Yeah, practice, and then you should explore. Then from whatever you get, you need to explore more. Yeah. Yeah.
Okay, so we move on.
Mm.
Okay, so for the patient's past medical history, as we said, diagnosed with retroviral disease, HIV, 2 years ago. Previous CD4 count 8 months ago, no, sorry, 6 months ago was 1,250 per millimeter square cube. He has a history of pulmonary tuberculosis diagnosed 2 years ago. Took medication but stopped 6 months after day one of treatment. So he took 6 months of the anti-TB therapy and then he stopped himself. Major depressive disorder diagnosed 6 months ago, 2 suicide attempts before, and 1 episode leading to hospital admission. And also alcohol use disorder diagnosed 6 months ago. So moving on. So for the drug history, so the patient was on tablet accurate / pyroxdixin 10 mg OD, triple antiviral medication, tenofovir, M3-citabine, and dolutegravir. The patient confessed that he is not completely compliant to his medication. Okay, so before we go on, just like to know, doctor, when you see this triple antiretroviral medication, does anything cross your mind?
Anything cross my mind?
Yeah.
What? Can you specify your question?
Is there any changes or in your clinical thinking when you see if, let's say, it's just maybe tenofovir is changed out to zidovudin? Any difference in the change in the drugs would cause any change in your thinking?
Well, this regime is currently being used like also part of the first line already, dolutegravir. So this patient can be on this as a first line, depending on when he was diagnosed as HIV lah, right? So if he was diagnosed as HIV earlier on, then we have to explore a little bit about the history of the HIV, whether was it any resistant HIV that prompted them to change the regime or not. But this regime is also the first line recommendation already lah by WHO, so may not suggest anything much lah.
I see. Okay, so let's just move on. Okay, so miscellaneous history would be allergic history, not significant. Family history, not significant. Social history, stays with family, mother and father, lives in Bukit Bintang. Used to smoke 10 sticks a day, stopped about 6 months ago. Currently on nicotine patch, drinks alcohol, used to drink 6 cans of beer per day, but stopped 6 months ago. Okay, so if there's anything, we can move on. Okay, so for the physical examination, for the vital signs, the blood pressure is 113 per 65 millimeter mercury, pulse is 112 beats per minute, respiratory rate is 16 breaths per minute, SpO2 100%, temperature of 36.5 degrees Celsius. General examination, alert, conscious, not in respiratory distress, not pale, not sinus or jaundice, no finger clubbing noted. Okay. Cardiovascular examination reveals no murmur, no raised JVP, no muffled heart sounds, and no pedal edema. However, on respiratory examination, we did note that there is some dullness noted in the left middle zone, reduced breath sounds in the left middle zone, and with increased vocal resonance in the same area. So this would point us to perhaps something that's more localized, like a lobar pneumonia, maybe.
Okay, carry on.
Okay, so a neurological examination is normal. Everything is normal. So now that we've come to the end of the physical examination, what do you think, doctor?
How about the abdominal examination? You said that this patient has vomit diarrhea. You didn't examine the abdomen.
Oh yeah, I forgot to put it in. I think if I'm not mistaken, it's not significant. That's why I didn't put it in.
Okay, so you have to always not miss out any system now when you examine this kind of patient, because they have this immune suppressed condition. They will have they potentially will have infection everywhere, anywhere. So you do not want to miss things like acute abdomen or some other more acute kind of situation, right? So just don't forget to examine the patient completely. All right, is that all?
I think that should be all. Is there anything else? Oh
Any
yeah, it's okay. It's done.
check PCP. All right, so the PCP, we can actually examine the sputum to look for this PCP antigen. Yeah. Okay, I have some slides that maybe I can share with you all. Okay, I'll just go to that. Is that okay?
Okay, sure, doctor. Maybe before that, we can take a break, about 3 minutes.
Oh, okay.
Just let them rest a bit until 3 lah.
Rest a bit, okay. You want to rest or just want to go on?
Okay, open the floor. Okay. Anyone? Nobody say anything. Do you guys want a break? Okay. Someone said can continue. Okay, can continue. Okay, so doctor, they are okay to continue.
All right. So wait, I'll share my screen 1 second.
Right.
All right. Oops, I look fail. Wait a second. Okay. File upload fail. What's going on here?
Can doctor?
Wait, you cannot upload the file. All right. Just give me a second.
Doctor, no need to upload lah. You just put the window .
Oh, I just go to that window, then can
I
already.
just go to the window, can already.
All right, hold on. You tell me whether you can see my screen on the slide. Can you see that?
No, not yet.
No, cannot.
No, still no.
Okay.
You need to open your PowerPoint first, doctor.
Yeah, open already.
Oh. Then you go down to window. Look under. Okay. I think it's up.
It's up?
I think so. It's loading.
Okay. Right. Great. So, all right. So just very quickly lah. If you got any question, just you can stop me halfway. No problem. Yeah.
Yeah.
Okay. Right. Can't seem to be able to control it. Do you see the slide moving? Changing slide?
Oh no. Because no. my colleague controlling it for you. Maybe do you want her to control it for you, or do you want to control yourself, doctor?
Maybe I can control myself.
So you have to press request control at the top of your slide. At the top, is it? Where is it? Oh no, it's there. It's slide 1 of 50, right? You can see the take control.
Oh, yeah. There's nothing there.
Nothing.
Wait. Wait, let me just enter full screen first. No, Nemala, your friend control for me lah. Can I?
Okay, I think she's okay with it.
Next slide. Can you change the next slide? Oh, okay, great. Wow, it's like putting up something and then get controlled by somebody else. All right. Okay. So just very quickly for this dengue assessment. Okay, next slide. Right. Okay. So 4 important steps of history taking, whether dengue or other disease. So you have to take a thorough history clinical examination, and send the investigation and all that to diagnose your clinically lah, right? Okay, next. Oh, I can click already. All right. All right. So the important steps in history taking, especially in dengue patients, the onset is very important because we know the phases of the dengue. So by taking the day of onset, we will be able to know at what phase that the patient that is in front of us is potentially at right now. Okay, whether they are in a critical phase, recovery phase, or the febrile phase, and what do we need to do? How much monitoring is needed for that patient? All right, and then each symptom and the severity, especially the warning signs, and the three golden questions, don't forget, are like how much oral fluid, how much urine, what activity can you do during the febrile illness, and whether there's any other source of loss of fluid like vomiting, diarrhea, and so on, and presence of any warning signs, and what are the other relevant histories, like whether there's any neighbor having dengue and all that, whether the patient is on any medication. Pay special attention to medication that might precipitate the bleeding, such as maybe steroid, NSAID that can cause gastric bleeding, traditional herbs which may contain steroid components in them, right? And whether the patient has any risk factors like DM, whether they are pregnant, they are obese, they are at special groups, whether they are very elderly, or whether they are infant, and whether they have hypertension. Why do we ask? Well, obvious, right? And whether they got any other exposure to other things. So you cannot just narrow down and be very sure that this is dengue and not something else. So don't forget about other things while you are working out this patient for dengue. Yeah, whether they have any unprotected sexual intercourse or any high risk drug use, things like that. And on clinical examination, very importantly, mental state, hydration state, hemodynamic states. Because the mental state that is impaired, if the patient is having a delirium and so on, that means the blood supply to the brain is already impaired. The patient could be in shock or compensated or decompensated. There's impaired perfusion to the brain because the brain is, well, one of the most important organ in the body. So your body, in a way, the nature has it will shun the blood away from the least important organ like your gut to one of the most important organ like your brain. So the brain is probably one of the last organ to go. So if the patient has restlessness, if they are lethargic, they have auto-mentation or even seizure, so they are in deep trouble. Yeah. All right. Then clinical evidence of warning sign like bleeding, whether they got any abdominal tenderness, enlargement of liver, any fluid accumulation, they have dullness in the base of the lung, they have this shifting dullness and so on. Other important signs include things like rash, whether they are tachypnea or not. It could indicate a shock due to hypovolemia or bleeding. Yeah. Tourniquet test you can do, but we don't really do that routinely anymore. And hemodynamic assessment, if you look at the parameters here, the conscious level, capillary refill time, the extremities, the peripheral pulse volume, the rate of the heart rate, the pulse pressure, the BP, the respiratory rate, and urine output. Well, these are some of the most important parameters that you should not miss, that must always be assessed. So the thing that is highlighted here actually indicates a peripheral perfusion, and over here it reflects the cardiac output, and the conscious level reflects your perfusion to the brain, and urine output as well, perfusion to the kidney, right? If somebody is losing fluid, losing blood, so there is less volume, the volume will be shunted away from the least important organ like your gut, and the next to go probably is the kidney when there's vasoconstriction, so that it can be shunted elsewhere that the body thinks is more important, like your brain, your heart, and so on. All right, and respiratory rate, you can have respiratory compensation when there's tissue hypoxia because of the hypovolemia, yeah? And in a stable circulation, yep.
Sorry for disturbing. Just like to ask, just now you mentioned something about tachypnea being compensation for metabolic acidosis. So just like to ask, where would that metabolic acidosis come from?
What do you think?
Maybe something from the kidneys.
What happens in tissue hypoxia?
Mm,
What would the body do if you have tissue hypoxia?
okay, so
It's okay.
they are saying,
You can look up the answer and tell your friends after this.
oh, they're all saying already anaerobic respiration,
Ah,
lactic acidosis. Got
yeah. Some of them might produce lactic, anaerobic respiration, things like that. Yeah, so that can be because your tissue there's hypoperfusion to the tissue lah. So there is tissue oxygen deprivation, tissue hypoxia. Then you have the subsequent compensatory mechanism, the anaerobic pathway, and so on. Okay. Right, so this is the stable circulation. Everything of the all the parameters will be normal. Normal brain perfusion, normal cardiac output, normal peripheral perfusion, normal kidney perfusion, normal, no respiratory compensation. So just now we have one patient, the first one has tachypnea. So most likely this patient is having this scenario in the body. Yeah. So in terms of the hemodynamic changes, so in stable, then we go to compensated shock now. So in compensated shock, look at the pulse pressure. So the pulse pressure is the difference between your systolic and diastolic blood pressure. So the difference in it, when there is a rise in diastolic blood pressure, as you can see from here very clearly, so the pulse pressure is narrow. So the systolic blood pressure may not drop, right, when the patient is in compensated shock, but there will be a rise in the diastolic blood pressure. So if the systolic remains the same, there is a rise in diastolic blood pressure. Plot the graph and be very careful, be very alert already that this patient might be in compensated shock right now and having narrowing pulse pressure. So it's important to look at the trend, all right, the trend. If there is any changes, any narrowing, be alert, okay? All right, so the heart rate can be raised, diastolic pressure can be raised, the pulse pressure will be lowered. Yep. And then as we all can see, the BP and is directly in correlation with the cardiac output and your systemic vascular resistance. Yeah. So if the cardiac output is reduced, the BP will be reduced and so on. If the cardiac output equals to stroke volume and heart rate. So to compensate, I mean, this is the very useful formula that we always use and we even use it right now. So to maintain a cardiac output, if the volume is less, so the heart compensates by raising the heart rate. Yeah. So by raising the heart rate, you are actually compromising on the stroke volume, right? Because there is less diastolic filling because the heart is pumping faster, right? So you have this reduced peripheral perfusion and what we call as quiet tachypnea. So in this phase of the disease, the patient might still be talking to you, right? Especially in a fit young person might be talking to you. You may have this false sense of security that the patient is well. So well is subjective. So we don't go by all these subjective well and looks well and all that. We don't want all the subjective assessment. So we go objectively, things that is measurable and reproducible, right? So where all these clinical parameters are important signs, objective signs that we can look at, that we can measure, and we can monitor, and we can act on it, and we can see the response. All right. So during this time, the patient is still lucid, but we have reduced urine output. So don't be too happy that the patient is talking to you and you think the patient is fine. The patient is not fine. You don't do anything, the patient is going to decompensate shock. Right? So in this case, the capillary refill time will be more than 2 seconds, or at 2 seconds, peripheries might be cool, the pulse will be weak and tready, and will be tachycardic for the age. The BP will still be normal, systolic, but the diastolic blood pressure will rise and cause a narrowing pulse pressure. Might have this what they call quiet tachypnea, and urine output will be reducing trend. Okay, so there is a big problem now, right? So we always want to act when the patient is not too bad, that we detect something small, some changes, that you know the patient is not getting better or getting worse, but not at the unsalvageable state. So you want to catch them early on when there is change. So this is a time to act fast and to prevent this patient from going downhill further. Because a lot of time when the patient goes further downhill, whatever you do, whatever you throw at them, the outcome is not good. Okay. Now this is compensated shock, right? And this is the last stage. If the patient go into hypotensive shock, if we didn't pick that if we didn't pick up the signs, then the patient is not treated properly. Then they will go into decompensated shock. So look at the graph. So there's narrowing of the pulse pressure, and then there will be a fall in the blood pressure already this time. Right? There will be increasing tachycardia. The pulses will be even more feeble or even absent, very thready even, and the blood pressure you will see a significant reduction. And the peripheral perfusion when you touch the patient will be cold, clammy, motile peripheral cyanosis, and capillary fill time will be very prolonged. Patient might be in close mouth breathing, and there is a reduced level of consciousness, oliguria, and urea. So key clinical signs of deterioration are like changes in mental state, such as restlessness, seizure, agitation, alternating with drowsiness. In infant or young children, if the patient is not able to recognize the parents, unable to focus or make any eye contact, because some infant young children, they cannot tell you what they feel, and the signs are different from adults. Yeah? So if the parent think that the child something is wrong with the child, always trust the parents. Yeah, don't disbelieve the parents' story, because they take care of their children. They know when the patient is not right. Yeah, but despite that, some young adults or children might still be having a clear mental state. That means the mental state is still intact. But look at the other signs and put all the things together. But they are at imminent total cardiorespiratory collapse. If you don't do anything now, stat, they are going to decompensated shock and might be irreversible. Okay. So this is the summary of the things that I just mentioned. Okay. And there are some pitfalls when we examine patients who has the dengue picture. We have to look at the big picture. So history is important. We want to know when it's onset. We want to know at what stage of the dengue fever this patient is in, whether they're able to take orally, and how much is the urine output, any warning signs, and what is the patient's pulse volume. And all the clinical picture, you have to put it in a package and not in isolation. You cannot just say that the conscious level is clear, therefore the patient is well. So you have to look at other parameters. If they have metabolic acidosis, they have tachypnea, reduced perfusion, despite them being able to talk to you, completely lucid, they are unwell, right? They are unwell. So you have to have this in mind. So a bit of the classification of dengue. Dengue with warning sign and severe dengue. Severe dengue are inclusive of those with plasma leakage, hemorrhage, and severe organ impairment. All right. So I think I won't go into the types of warning sign. You all should know. You guys are third year, right? Or fourth year? You guys are fourth year?
Third year and above.
Third year, okay.
Yeah, most of us are third year. There are some who are actually from another university. There are like a couple of them. Some are already graduate. I think 2 of them. I'm not sure if they joined this session.
Oh, okay. They haven't get the contract yet.
I'm not sure if they are in.
Yeah, okay. So, overview of the clinical manifestation. I'll just go through a brief summary of things. The clinical course, you must always remember, dengue, a lot of us just think about platelet counts, right? Platelet count, okay, it's a disease of platelet count. Then you forget about the warning signs, the fever, and the other symptoms. But dengue is not just a disease of the platelets, yeah? So it's a systemic disease, And it is a very fluid and dynamic disease that that we need to act very fast. We have to follow up on our action very fast, right? So it's not just a platelet disease. And this is the cause. We have the incubation period, and then we have the febrile phase, which commences at the symptom onset, and then critical phase happens when there is a drop in temperature, when the patient goes into effervescence. This is probably the most dangerous phase of this disease. And then we have the recovery phase. So when all the plasma leakage resolves, then the patient is on the way to recovery. So this is a very, very important graph that you all have seen, but probably we can just quickly go through. So we have the febrile phase here up to day 3 to 5. And then we have the critical phase, usually lasts about day 3 to day 7. It usually lasts about 24 to 48 hours, critical phase. And what happens in the febrile phase is the patient will be probably dehydrated if they are not feeling well, not taking orally. And then in the critical phase, the patient might go into shock. And during this time, if you realize the graph, the platelet will drop during the critical phase and come up back during the recovery phase. Hematocrit will rise during the critical phase because most of the dengue patients will have some plasma leakage, right? Just that whether the plasma leakage is severe enough to cause noticeable signs or not, like your effusion, your shortness of breath because of effusion, or your ascites, or it might be very subclinical, very mild leakage. It happens, but it's not noticeable, and the patient is still well able to tolerate orally. Then we don't really have to worry about that, yeah. And the white cell will come down during the critical phase and will return back to normal in the recovery. And this, the febrile phase, is when the viremia occurs. And toward the end of the febrile phase is where our body responds by producing antibodies, IgM and IgG. So IgM will be detectable usually about day 5 or day 8 of the illness. Okay, so shock, bleeding, organ impairment usually happens during the critical phase. And these are the vignettes of febrile phase, usually lasts 2 to 7 days. All right. Quality of life may be affected. Nausea and vomiting may be a prominent feature in children. In adult, probably they will have inability to concentrate or focus at work, or they will neglect their personal care, like for example, somebody who groom themselves very well, you know, they are just so tired they don't bother to comb their hair when they attend this meeting. But Hai Liang had the haircut and groom. I mean, things like that, yeah. So might have some change in the behavior and the mood, very irritable and so on. Right, so when you transition from febrile to critical phase, usually on day 4 to day 7, sometimes can be as early as day 3. It will coincide with the phase of dropping in temperature when the patient no longer having fever. This is the time when we have to monitor more closely, right? And development of warning sign. We have to be able to identify dengue patient who is in shock already or who are at risk of developing shock. Because we don't want to detect them when they are very late in the disease, because during that time, sometimes it's irreversible, or you know, they will have some very bad sequelae from that. So we have clinical warning sign and laboratory warning signs as well that we have to watch out for. And there are some pitfalls that some doctors, some young doctors might miss certain signs. So what is significant abdominal pain? So it is significant when the patient describe it as their chief complaint. You know, you have some abdominal pain, but this is like so bad that they present them to you as their chief complaint. And sometimes it's so bad that it can be mistaken as a surgical condition. So that is significant abdominal pain. So what does it signify? Right, so as usual, it's like the hypoperfusion due to plasma leakage, no more blood to the gut, hypovolemia, and it's vasoconstriction there because you don't need the gut in a flight or fight situation, right? Adrenaline and all that is going to cause vasoconstriction to the gut. vasodilation to your more vital organs. But then there's some pitfalls. Tense abdomen due to ascites or liver congestion due to the leakage can also cause abdominal pain. Yeah, so you have to be careful here, as in whether it's hypovolemia that is causing hypoperfusion to the gut that is causing the pain, or whether it's the pain caused by too much fluid that you give. Right? If you give too much fluid, too fast, too much, and the leakage happens so fast, it goes to the gut, and it causes plasma leakage, it causes ascites, it causes liver congestion, then that is causing the pain. You have to cut down the fluid. You get what I mean? So it's a delicate balance there. You cannot give the patient too much fluid because that is going to cause a lot of leakage, right? And then you will have trouble when there's reabsorption, especially into the lungs. The patient will have pulmonary edema. Then you will have trouble managing the patient because you might need to intubate, and all the risks that are associated with intubation, like hypotension, arrhythmia, all that comes with intubation. Those risks are there. But you cannot give too little, because if you give too little, when the intravascular volume is low, if you don't give enough, so you're not helping with the tissue perfusion. So the logic is like this: the blood vessel is leaking, right? The blood volume is there, it's reduced because it's leaking out into the third space. So you have to give the IV drip enough to maintain the perfusion in the volume inside the blood vessel, so that your vital organs, your brain, your heart, your kidney, and so on, your liver, has adequate perfusion so that they receive adequate oxygen and other stuff, right? But you cannot give too much, because if you give too much, more than what is enough to perfuse the vital organs, then all this is going to go out to the third space, right? So imagine a pipe that all goes out to the third space. So that is going to cause you a lot of ascites, a lot of pleural effusion. A lot of pleural effusion, a lot of ascites is going to spleen the diaphragm, it's going to cause compression of your lung, then they cannot breathe, then they have shortness of breath, then you panic. Okay, so you need to give, but you cannot give too much. So it's a delicate balance here, right? So it's like your yin and yang, it has to be balanced. You cannot have too much yin and cannot have too much yang. Right? So it's like the ancient philosophy, right?
Doctor, the audience have a question. So Pan Kamon asked, Doctor, can you please explain about antibody-dependent enhancement? And secondly, any special precautions to be taken in thalassemia patients with dengue?
What do you mean by antibody-dependent enhancement?
I'm not sure, but I think, oh yeah, that's the answer. You want to answer, Pan?
Yeah, go on.
I think what she's meaning by this is the serotype, the difference. Oh yeah, okay. Patient with history of dengue has severe dengue.
Right. So like it's like before that had antibody to dengue because had previous infection, right? Okay. So so if this patient is being infected by another strain of dengue, like we know there are 4 strains. So if they are infected by, for example, Den1, and then now they have Den2, they have antibody IgG against Den1, but they do not have antibody against Den2. So this memory cells and all that is going to produce IgG faster. The memory cells is going to produce the antibodies faster against this new dengue virus infection. So the response of that can be more profound. Basically, that is what it means lah. So in terms of that, so the reaction to this response can be more severe. Okay. So thalassemia patient with dengue. Well, the principle of management of dengue fever generally is still the same in terms of maintaining the fluid balance. Watch out for the warning signs and the bleeding, right? of course, in somebody who has thalassemia, we have to see what kind of thalassemia, because thalassemia, whether it's A or B, is a spectrum of disease. You have the very, very mild one that doesn't require transfusion at all throughout their entire life, to the one that, you require like monthly or 2 weekly kind of blood transfusion and all the problems that come with it subsequently. So we manage the dengue, manage the fluid balance, and at the same time, we have to also, in thalassemia patient, their HP might be a bit on the low side. So we have to monitor that part. And maybe if there is bleeding, then we have to transfuse, just like any other dengue patient. Not much of difference, but because the thalassemia is something that is chronic, somebody who is living with a HP of around 8 or 7 for many years and now have dengue, so we might not want to rush to transfuse this kind of patient if that is their baseline. So we go by it's a case-by-case basis. Yeah, so we will monitor the patient closely and manage like any other dengue patients, but bearing in mind that they might have a lower baseline HP, all right? Okay. So persistent vomiting means more than 3 times per day, and it signifies plasma leakage as well. Well, when is lethargy more than usual? Because if you did not have enough rest the night before, today you might have a bit of tiredness. You call it lethargy. But what is the lethargy that you want to be alert and be very cautious about? So things like the patient is confined to the bed most of the day, right? Or patient sleep most of the time, is uninterested in food or favorite television program, and is too weak to even to walk to the toilet. So that is significant lethargy, all right? So always remember, restlessness equals to severe shock and cerebral hypoperfusion. You might come across a patient who comes to you that is very uncooperative, right? They are restless, they are uncooperative, they move about, they pull their tubes and needles out and so on. So this is a sign of restlessness. So it's a sign of cerebral hypoperfusion. And mucosa bleeding is a warning of more severe manifestation. Fluid accumulation due to your plasma leakage can be mild. Most of the time, in most of the dengue cases are mild, but it can be severe, especially iatrogenically if we give too much fluid too fast. Yeah. Leukopenia is a laboratory warning sign. Rapid decrease in platelet and rapid rise in hematocrit is also a laboratory warning sign. And this is what happens in the critical phase. Increase in permeability of the vessels, plasma leakage increases, there's development of warning sign, and deterioration of the patient's condition. All right. And the plasma leakage usually lasts 24 to 48 hours. And shock occurs when critical volume of plasma is lost through leakage. It is often preceded by warning sign. Somebody don't just come and just shock like that, yeah? So it's preceded by warning sign. There's hypoperfusion signs and so on before it comes to compensated and subsequently decompensated shock, right? And then the body temperature may be subnormal when shock occurs, may not have fever. The total white cell count may increase in patient with bleeding at this stage. Okay. So what will happen without treatment? The patient will die. Okay. So these are the pearls and pitfalls in a dengue shock. So dengue shock is a continuum. It's a physiologic time continuum. It's not a independent factor, independent situation where just come with shock like that. So you have to catch it early. It's a spectrum of a continuum. So in the early stage, there might be normal or elevated BP. Decompensated shock. In the late stages, you have hypotension and unrecorded BP. So you have stable dengue. If nothing is being done, orally or IV, then you go to have warning sign. Then you have compensated shock, and then you have hypotensive shock, and then you have cardiac arrest. So if you're able to identify early shock, it will improve the clinical outcome. If you delay the treatment, if you are not able to pick up the signs, you let the patient be, the course will the course will progress and the patient will get worse and will die. All right? And if there is bleeding, it will exacerbate the shock state. So it is very easy to miss dengue shock if you are not able to pick up the signs. All right? Because sometimes in a shock state, the patient can appear deceptively normal or seem stable, yeah, with a lucid conscious level. So you must be thorough, you must be careful in your physical examination, you must identify the critical and the critical signs of the patient before the stage of cardiovascular collapse. All right, so recovery phase, what happens? So the permeability will return to normal, and gradual reabsorption will occur in 48 to 72 hours. So if you see this rash, the island of white in the sea of red, the classic rash of dengue, that means this patient is already in recovery phase. If the patient is starting to produce urine, that's a good sign because the kidney is receiving adequate perfusion right now. But the patient might have some biphasic phase, the AM pattern kind of spike of temperature during this time. May have bradycardia, heart rate may return to normal during this time instead of tachycardia, and this rash. And laboratory-wise, you will see a stabilization of the hematocrit, white blood cells start to rise, platelet will start to rise as well. Okay. So don't forget the differential when we think about dengue. So think about because dengue can mimic many clinical syndrome as well, like flu-like illness, viral exanthum, acute abdomen, other infection, bacterial infection, autoimmune diseases, or some hematological disorders. So we must understand the dynamic and systemic nature of the dengue, and knowing its various manifestation as the disease progress from febrile to critical to recovery is important. So this slide shows you a summary of how to manage dengue. So not all dengue patients that we need to admit. So there's a group that we can send home. If they're able to drink enough, able to pass urine every 4 to 6 hourly, no warning sign, stable bloods, no existing premorbid condition, right? They are not alone at home. They're able to come to the hospital if anything occurs, then you can send them home. If they have any warning sign or if they have any underlying existing conditions such as diabetes, kidney disease, they are pregnant, they are infant or they're elderly, or socially they have difficulty to come, then you might want to admit them for close monitoring. Of course, then there's another group that is more severe, don't discharge them. All right, and then, this is not dengue, this is like the case, one of your case that has prolonged fever for 4 weeks. So I roughly come up with something to help you with it. So you have to divide the differential into infection, connective tissue, malignancy, and drugs. All right, so that you don't forget, you have these big groups in your mind, then from each big group you branch out to narrower potential diagnosis. So in infection, things like OM, melioid, TB, non-tuberculous mycobacterium, abscesses, endocarditis. Connective tissue like diseases like adult steels, giant cell arthritis, SLE, depends, yeah? And malignancy and drugs. Certain drugs does cause fever, penicillin, some aminoglycoside and other drugs can cause fever in some people. And in the case that you presented with a prolonged cough, right? So not just TB that you have to think about, you have to think broadly as well. TB, of course, you have to rule that out, but you have to gather from history, physical examination, and of course, a radiographic finding, whether is it bronchiectasis that the patient is having. Bronchiectasis also is another cause of, another common cause of hemoptysis in a patient, okay? Cough and hemoptysis besides TB. Besides malignancy, then it's bronchiectasis. Whether the patient is having COPD, because COPD patient, they will have cough. Every day they will have cough. But just whether is that the baseline cough or, the intensity of the cough is increasing because there is some precipitating factor like infection or other other precipitating factors. Whether the patient has asthma or airway hypersensitivity, any precipitating factor like cold drink, cold weather, cold air that precipitate a cough, whether it's worse at night and better in the daytime, that could be suggestive. And you look at the white cell, I mean, like if the eosinophil is high and other clues, right? And then malignancy, if you have a mass in the airway that is constantly stimulating your airway, then that can cause your chronic cough as well. So your history in terms of progressive symptom, worsening, increase in intensity, increase in frequency and all that, then it's probably a malignancy that the mass is getting bigger. And certain drugs like ACE inhibitors can cause cough, yeah? So you have to correlate with the timeline when the patient was started on ACE inhibitor or other drugs that potentially could trigger the cough. So another case that you had was TB on treatment, but there is no improvement. So there are a few reasons. One reason is like we know that he's not compliant. So we are not very clear whether the patient is not compliant to his RVD medication or not compliant to his TB medication or not compliant to both. Most likely it's both because there's no reason for one person to comply to one drug and not comply to the other, unless they cannot tolerate. So in terms of the history taking part, make sure that if you have found that there is no non-compliance in part of the patient, try to gather more information like what makes the patient don't want to take their drugs. Is it because the pill is too big? The pill burden is too much. There are just too many pills to take. They are elderly. They are not able to sort them out themselves. Nobody to help them, right? Or whether they cannot come to the hospital daily for these dots because financial problem or physical problem. There's no help that can bring them here, or there's nobody at home that can come and help them to take these medications. You have to explore that as a clinician so that you address all these issues so that after you sort out this issue this round, so that the patient don't come back again with the same problem of non-compliance. Because it's very easy for you as a clinician to say like, okay, the patient is not compliant. Because the patient is not compliant, that's why he's not getting better, right? But it is your responsibility, it is our responsibility to find out what is the cause of them being not compliant and address them. Not all of them are like don't want to take the medication because they don't want to take the medication, because it could be some other problem that they might be having that impairs their access ability to take the medication or other reasons. So we need to explore that, right? Then you have done your part. Yeah, don't just put the blame on the patient. Okay. And the other important thing is whether this TB is a resistant TB, whether it's a multi-drug resistant TB or XDR TB, extensively drug resistant TB. Well, I won't go into details, but if the patient on and off on some antibiotics, the TB can develop resistance, or they might have resistant TB to begin with. Yeah, so these are the things that we need to think about. And also explore the culture and sensitivity of the TB specimen. And the other thing is whether your local clinic dots is actually, bringing the patient back or not. Because some clinic, because your dots, suppose you should bring the patient to the clinic every day. But some of them, for convenience sake or don't know for what reason, they will just give the patient like 1 month supply or 2 month supply of the TB medication, right? So when they just give like that, the patient go back with the medication, they might just put it aside and not really taking it. So whether that's the scenario or not, you need to think about that as well. Okay, then another case you have in this untreated HIV, well, you have to think about OI. In non-HIV cases, you have to think about other immunosuppressed condition on any immune modulatory drugs. Okay, I have a few quizzes here. What do you think is this? Anyone want to try? Teo Ipeng want to try? Teo Ipeng? Aaron? No. Gladys want to try? Gladys? or Lu Kim Ki?
Kai Xiang said mosquito eggs.
Oh yeah, correct. Mosquito egg.
Gladys say baby worm.
Yeah, no, it's not baby worm, Gladys. They are not worms. They look delicious to you, is it? Like pudding? Well, they are mosquito eggs, correct. But what kind of mosquito egg? Do you know what mosquito lay this kind of egg?
Kai Xiang said Mansonia.
Mansonia? No. You want to try? Hai Liang, you want to try, Hai Liang? Not Aedes.
Not Aedes.
Not Aedes, Aaron.
Adrian said Anopheles.
Yeah, correct. This is a egg of Anopheles mosquito. So you look at the pattern. I mean, yeah, it's like the pattern. They lay eggs in this pattern. So it's called a raft pattern. It's like a racket, raft. Raft. I mean, I put this up picture because maybe some of us English not so good, so don't know what is raft. So this is raft lah. So this is a racket, yeah. So the egg is in a raft pattern. So this is Anopheles. How about this? This is another species. I mean, this is another mosquito egg. So we look at the pattern. So, well, it's like a rice like that. I don't have the size here, but if you look closely, there is these floats at the side here. The floats, the pelampong. Pelampong, you guys know, float. For those English not so good, float, you know. So float is something like this, a float, yeah. So that when the mosquito lay egg, these eggs will float. So that's why it's called a float lah. So this is Culex eggs, right? Just give me a second. Okay.
Doctor, Lao Kai Xiang asked, are raft eggs more towards Culex species?
Oh yes, sorry. It's Culex rather than Anopheles. So the rough one is actually Culex. The float one is actually Anopheles.
Okay, thank you, doctor.
Yep. Sorry. So the rough is Culex and the float is Anopheles. All right. How about this? This egg looks evil. It's dark. It's black. It's evil. So
Mosina, maybe? I don't know. Just guessing.
Aedes eggs is like this. Okay. Aedes is very hardy. The eggs are very hardy. It can survive in a, you know, if they lay egg in a pool of, in a puddle of water, the puddle of water actually dries up. The egg is still there, right, on the land or wherever. It can tahan, you know. It tahan. It won't die. So if it rains again, then all this is gonna hatch lah. They will hatch, and yeah. So these are Aedes eggs. I see that your chat here you have Anopheles walkeri. Is that from Star Wars? Well, there are a few species of Anopheles. Yeah, so we don't really have to know the species over there. So how about this? Okay, there are two questions here. Whether it's a male mosquito, of course, everybody knows it's a mosquito, right? So whether it's a male mosquito or a female mosquito, and if you know what mosquito is this, male or female? Lao Kai Xiang, you want to try Lao Kai Xiang? Or Li Ling Yi, you want to try? What is this? So it's a male or female mosquito? Gladys, you want to
Lao
try?
Kai Xiang said male Colex. Melissa said female. Li Ling Yi say male. Gladys say female.
Ooh, okay. Are you guys guessing? Well, so there are a few features that you look at the mosquito. Well, this is part of tropical medicine lah. That's why I put out some of these so that you don't sleep away, sleep off, and all that. Anyway, we have done with the more important part of dengue management, so we just have some fun identifying all these important factors. All right. So you look at the antenna here. Can you see my arrow moving?
No.
Cannot. Oh. You cannot see my arrow moving. So if you look at the antenna. If you look at the antenna is very bushy. The antenna is very bushy, right? So this bushy antenna is to detect the pheromones or some chemical that is in the air. So these bushy things, bushy mosquitoes, bushy antennas belong to male mosquitoes. So these male mosquitoes have this bushy antenna so that they can detect where is the female. Then they will be attracted to the female, the chemicals, the hormones that is released by the female, and they are drawn to the females, right? So this is an anopheles. You look at the proboscis, that is suck blood, right? Then you have the palps, the two thing there with the bulb at the end. Those are called the palps. So the palps is as long as the proboscis. So this is the feature of anopheles. So this is a male anopheles. Okay. And how about this one? So this looks like a human hand, and this is the mosquito. So what do you think is this? So you then again the few features that look at is the proboscis and the palp, besides the stripes, whether it's present or not in the body lah. So there's no black and white stripe that is characteristic of Aedes. So the palp is very short, not like this. The palp is very long, right? So this is very short, and it's shorter, very much shorter than the proboscis. So this is a Culex mosquito, and it's a female because only the female bites, right? So only the female bites you. So this is very obvious lah, Aedes, right? So there's two famous Aedes here, Aegypti and Albopictus. You're able to differentiate it actually by looking at the pattern on the thorax. So this is a female Aedes mosquito. Right, how about this one? Can you guys see what mosquito is this?
Male.
Male, yeah, bushy. You saw the bushes.
And
Yep.
Colex. Not Aedes.
Culex. No, it's not Culex. If you look clearly, yeah, this is not the best picture, but if you look clearly, there are black and white stripes along the abdomen and the trunk and the legs there. So it's a male Aedes. So what can, this Aedes mosquito, this mosquito can transmit? What disease? Melissa, you want to try Melissa? Or Lingy, or Gladys, or Ruben?
Lao Kai Xiang said dengue and Zika.
Any more?
Kao Pei Yi said chikungunya.
Yellow fever.
Oh, Ling Yi also. Oh, male doesn't bite. Yeah.
Okay, good try. But male mosquito don't bite you. All right, so they cannot transmit you any disease. Gotcha, right? So it's a male mosquito. It's a trick question. Yeah, so it doesn't bite you. Only the female mosquito bites you lah. All right. Okay, that's all from me. You got any question? Any question from the floor? Everybody is good. I hope you guys learned something from today's session.
Okay, if there are no questions, then maybe you can call it a day.
Okay.
Okay, so first off, I'd like to thank Dr. Ong for agreeing to attend this session.
No
and I
problem.
thank all of you guys for coming. Okay lah, I think that's all we can end the session already. Okay, thank you, doctor.
Okay, bye-bye.
Bye-bye. Bye-bye, doctor.
I'll log off. Take
Yeah,
care.
sure.
Stay safe.
Bye. Thank you.
Safe. Don't merayau-rayau and go party too much.
Okay, okay.
So,
Back
physical
for
distancing. You shouldn't be social distancing yourself. You should physical distancing. You should still be socially connected, but not physically without being physically crowding with each other.
Yeah.
You can still by online, Zoom, or whatever lah, video call and so on. Okay. See ya. Bye-bye. Thanks, Halia, for organizing.
Okay, no problem, doctor.
Thank you, doctor.
Bye.
Bye-bye.
Ayo, how to log off? Oh, how do I log off this thing?
You press the red color button at the side there. Can the red call button.
Okay. Hey, how do I log off? Okay, we can log off, right?
I just press only, press off.